So I'm going to talk about SAVR for aortic stenosis and mitral regurgitation. Many subjects of this topic has already been discussed from the previous presenter. Multiple valve disease is an intricate clinical scenario, and the combination of aortic stenosis and mitral regurgitation is a typical example. Combined aortic stenosis and mitral regurgitation is a rather interactive synergy with important pathophysiologic, diagnostic, therapeutic, and prognostic implications. Surgical and transcatheter treatment have been applied, but less is known about the optimal treatment, and there is low level of evidence in the interventional guidelines. Several severe aortic stenosis and significant MR coexist in up to 1/3 of the patients who undergo intervention for aortic stenosis, and the respective natural causes of the two valves diseases are not synchronized. The hemodynamic interdependency of aortic stenosis and mitral regurgitation tends to confound the assessment of the severity of each valve, thus underscoring the importance of a multimodal approach, integrating valvular and extravalvular indicators for valve disease severity. As you can see, analyzing pathology and etiology, severity, and the supporting signs are going to give us the complete picture of this complex pathology. Most commonly, significant aortic stenosis is deemed the prognostically leading pathology in patients with combined aortic stenosis and mitral regurgitation. The guidelines recommend that aortic valve intervention may be considered in patients with moderate aortic stenosis who are undergoing cardiac surgery for other indications. Eliminating mitral regurgitation before treating severe aortic stenosis can cause a sudden increase in afterload that might lead to cardiac decompensation. Therefore, it is generally recommended to treat aortic stenosis before mitral regurgitation. Studies supports early intervention in patients with aortic stenosis, and there are ongoing studies assessing the benefit of aortic stenosis intervention in patients with moderate aortic stenosis with symptoms or evidence of cardiac damage. Less common scenario, when MR is deemed to be the leading pathology, mitral valve intervention can be performed first, followed by guideline-recommended management of moderate aortic stenosis. Significant baseline MR was associated with significant higher rates of early and late mortality after aortic valve intervention compared with non-significant MR. Outcomes of patients with functional MR were comparable with those in patients with isolated aortic stenosis. Staging rather than grading of aortic stenosis is pivotal in the prognostication of aortic stenosis, as well as predicting the benefit of futility of aortic stenosis intervention. And as you can see, staging integrates the extent of secondary cardiac damage into the evaluation of aortic stenosis. And therefore, if we have improvement of MR more than one grade in up to 30 days after aortic valve intervention, and if the predictors of MR are absence of atrial fibrillation and the presence of coronary disease, the severity of the degenerative MR could also regress after aortic valve intervention. Therefore, a stepwise approach allows us reassessment of the concomitant MR after aortic stenosis intervention. There are some predictors for regression of mitral valve regurgitation regression after aortic valve replacement. And there are some predictors which have been derived from the transcatheter treatment first of aortic valve, following later on in mitral valve. So the strategies from the surgical point of view are either a concomitant bivalvular surgical intervention or surgical replacement of the first valve and staged transcatheter intervention on the second valve in the second stage. Of course, there are pros and cons in each procedure. For the limit of time, I cannot analyze all these predictors. From this algorithm, I would like to focus on the surgical candidate. And as you can see, we have a severe aortic stenosis and mitral regurgitation, severe. We vote suggested, recommended, concomitant SAVR and surgical mitral valve replacement. If the primary, the same as if the mitral regurgitation is from primary etiology. And if there are moderate aortic stenosis and moderate or severe MR, in moderate conditions, we prefer medical management if there are other indications for CABG or other cardiac surgery. So for this other algorithm, you can see that SAVR is recommended only in these three cases, either in low, intermediate risk patients with non or mild MR severity, in patients with severe mitral regurgitation who are in low or intermediate category, they have double valve procedure, but in high-risk patients without severe mitral regurgitation, only if there is a contraindication for TAVI. So from a registry, the risks are high in double valve replacement. So for this registry, we can see that the hospital mortality for SAVR and mitral valve replacement is 9.9%. Of course, the repair, mitral valve repair, lowers the risks. So in conclusion, studies are needed to determine the ideal treatment strategy and timing of intervention. And in the meantime, the role of the multidisciplinary heart team is key and crucial for designing and allocating to the optimal management strategy. And we have to take into consideration all available diagnostic and prognostic data, along with the patient's expectations and priorities. Thank you.
Thank you very much. So that, like I said, the big problem is for the cardiac surgeon whether to have to replace both valves or just one valve and wait and see what happened with the mitral valve. So before you take your decision, you have to look at the patient, you look at the leaflets, you look at the atria, because if you have atrial FMR, probably he will be better after the replacement. You look at the ventricles, and then you decide when you have to make both valves at one time, or you have to wait and watch how the mitral valve, the MR, is going to be. If we have some question for the audience, and then we can move to our last presentations. Thank you very much.
Thank you.
Thank you very much.